this week on the Back Table Podcast.
Yeah, I think what I've seen and personally is that technology has kind of upped everyone's skill by a notch. So people are doing things that are performing at a higher level than they were before. Wherever they were at before, they're doing better. So that's basically what we've seen. And the other thing that I didn't appreciate, I'm pushing 50 now. And at the end of doing like 5, 6, 7 cases in a day, my back's aching, my shoulder's aching. The surgeons appreciate this more than medicine docs in general, I think, and they've been aware of ergonomics for a long time. And the ergonomics is just night and day.
All right. Well, welcome back, everybody, to another session for Lung Cancer Weekend. I have 3 guests with, my co-host, Scott Genshaft, and 2 more guests. Let's do a quick round of introductions. Scott, you want to start?
Hi, I'm Scott Genshaft at UCLA. I'm an interventional radiologist.
I'm another Scott, except my name's Scott O, and I'm an interventional pulmonologist at USC.
I'm the outsider and the only non-Scott. I'm Kavi Krishnasamy. I'm an interventional radiologist at UAB.
And I'm Scott number 3, Scott Atai from USC. I'm a general thoracic surgeon.
Awesome. Well, thanks everybody for being here. We will affectionately call this Scott Cubed plus Kavi. So we're going to delve into the surgical side of lung cancer, primary lung cancer today. So let's get started with lymph node staging. We talked a little bit about bronchoscopy. Obviously, we're well acquainted with PET-CT. Where does mediastinoscopy fit into this?
It almost doesn't fit in at all anymore. It's a very small, it's a very fractional percentage of patients. So really, mediastinoscopy in most practices now is reserved for patients with a discordant findings. So a PET scan with metabolic nodes and an EBUS that shows no disease, where you just have a very high expectation. That is almost the only time that we would deploy mediastinoscopy anymore. And even then, we kind of hedge sometimes where if the EBUS seems good quality, again, this is, we have a lot of faith in our interventional pulmonologist. So if we have a high quality EBUS, we see lymphatic tissue in all of the specimens. I'm going to say I believe it. And then I'm going to do the lymph node dissection anyway. And that's what's going to happen. If we find a cold disease, well, as I think we talked about earlier, if we find a cold nodal disease, that upstages them enough that we have to think about, did we impact their outcome by not giving them neoadjuvant chemoimmuno, or do we know based on Empower 10 that adjuvant with immuno, they're still going to do pretty well. So, and even with MEAD on top of that, the ability to achieve the stations that EBUS can is actually more limited. EBUS can get a little bit further out. We really only get those very central stations. You can do extended mediastinoscopy, get a little further. Nobody really does that anymore. But so yeah, even then, I really am only getting those very central 427, Scott O, Scott number 2, he's going to get number 1 in our hearts.
Great.
He's going to be able to get out to those level 10, those higher nodes that I can't see, which even still will impact the decision for neoadjuvant. So we really don't deploy that frequently.
Yeah, I'd like to add to that. I mean, as the data for perioperative systemic therapy just becomes more and more compelling, we've always known that staging is important, but it's just that much more important, again, like level up on the importance of appropriate mediastinal staging is that much more important as the perioperative data continues to come out quite positive. It's really, I think, important. The other thing that I'd like to emphasize is that when necessary and when indicated, it's probably a good idea to do combined EBUS, EUS to complete the mediastinal staging when, depending on the location of suspicious lymph nodes. So it's not just bronchoscopic, it's EUS, and those two things combined, I think, give you the most complete, minimally invasive approach to staging lung cancer.
In my practice as an interventional radiologist, we treat a number of small peripheral relatively indolent appearing lung cancers. And for many years, we would rely on PET-CT and forgo mediastinal lymph node staging. After a forthright conversation with the patient, they would just elect to not have that done. And the concept would be, yes, unfortunately, yes, some may fail, and we're going to deal with that on the back end if they were to recur. Do you think with the emerging evidence, we need to really seriously reconsider this and send them reflexively to an interventional pulmonologist?
I feel like there's 2 clinical scenarios in that situation. There's the high pretest probability of radiographically occult mediastinal disease, I think those patients should get invasive mediastinal staging via bronchoscopy or EBUS EUS. Then there is the very peripheral subsolid, maybe even sub-centimeter type lesion, where radiographically occult mediastinal disease is negligibly low, maybe not zero, but really low. And if that patient locally, their local expertise gets them to a diagnosis of lung cancer quicker by getting a CT-guided biopsy, that's what they should get done, because the chances of it's not worth waiting to get an EBUS done in those patients. And if they get sent to me, or if I see a patient with lung cancer already diagnosed, and it's a small peripheral lesion, they've had a PET CT and the mediastinum is clean, I'm not going to delay sending that patient to our thoracic surgery colleagues for treatment to do an EBUS in that patient, because I don't think it's worth putting that patient through another procedure where I think the contribution to the data that we'll get is not going to really contribute to the patient's management. That being said, if I have a patient with a nodule that I think I can sufficiently biopsy with a bronchoscopic approach, and I'm there anyways, I'm going to put my scope down and survey the lymph nodes because I'm already there. For that exact same patient, if they come to me without a diagnosis and I'm going to be doing a bronchoscopy, then I'm going to take advantage of that situation and survey the mediastinal the lymph nodes while I'm there, because it doesn't add much time and it doesn't add much risk. And every once in a while, we'll add a significant amount, meaningfully impact the patient's care.
What prompts you to perform a biopsy on those lymph nodes while you're performing the lung biopsy?
Yeah, it's a great question. We do kind of a systematic survey of the 2s, the 4s, the 7s, the 10s, and the 11s are typically the stations that we look at systematically. And if we find a target that's 5 millimeters or larger, we usually biopsy. That's kind of our threshold. And a kind of mediastinoscopy replacing EBUS surveillance and biopsy, if you end up biopsying 3 or 4 stations, that can take a good 45 minutes to do. So it adds time to the procedure if you find that. That being said, there are cases where, if you see this perfectly round, well-circumscribed lymph node, that's like 4 millimeters, not an infrequent rate, those will end up being positive. So I think there's some ultrasonographic characteristics that have been reported that predict a higher rate of malignancy. So sometimes we'll go after even smaller lymph nodes if they look particularly suspicious, even when they're smaller than 5 millimeters.
And when you're biopsying these lymph nodes, it's a core biopsy?
I think the definition of a core biopsy, I think is, to me, still unclear. We use a 19-gauge needle. If we think it's a lymphoma or a granulomatous process like sarcoid or a weird epithelial carcinoma, like you get a 24-year-old that never smoked that looks like it's a lung cancer, you're like, this is something strange, then we know that intranodal cryobiopsies adds a significant amount of additional diagnostic performance. So we selectively do intranodal cryobiopsies for particular cases. We also tend to do that a little bit more in redo EBUS cases where there wasn't enough tissue for next-gen sequencing and moleculars the first time around. We'll do intranodal cryobiopsies the second time around to help ensure we get enough tissue for that type of analysis.
Are there any stations you can't get to?
Oh boy, yes.
I know there's nothing probably, but you
can
get to it all. But
5 and 6 are always the hardest, right? Because it's on the other side of the aorta and the other side of the PA. Now, this is off-label use, but with the peripheral bronchoscopy systems now, people are performing station 5 and 6 biopsies, going kind of the end-around route, where you go through the airways and then and head back towards the mediastinum, but not with linear EBUS. There have been reports in small case series of transvascular biopsies, but those are pretty extreme situations and not something that we would, I think, do routinely by any stretch.
Yeah, it's interesting as interventional pulmonologists get more and more aggressive with the corresponding good outcomes, there's less of a need for us to then go transthoracic into the mediastinum to do a percutaneous biopsy. I've done it. I'm sure you've done it as well. I'm willing to do it. If somebody, if we have that multidisciplinary conversation, we just can't get there and we need to target something. But yeah, the technology continues to optimize and improve.
Yeah, it's like, things evolve so quickly. And again, you need the local expertise and the local equipment to be able to do it. So I think a lot of this is going to be driven by what's locally available where people practice.
Great. Let's change gears a little bit. Let's talk a little bit about patient selection, comorbid conditions, respiratory status when you're taking a patient to the operating room.
Yeah, so anytime we're thinking about a lung resection, we have to assess their ability to tolerate the volume loss of the lung. So we do routine pulmonary function tests, which includes spirometry as well as diffusion testing. So we want to know lung volumes, essentially whether they're moving enough air. And we really want to understand the functional component of the lung, which is the diffusion. So is the cardiopulmonary component working? And so we send them off to our pulmonologists, who will usually have a lab. We'll get those results. And then we make a decision with the patient. In general, most of the guidelines from the thoracic surgical societies will say you can drive a patient down to 40% of predicted post-operatively. So that means we calculate out the lung volume loss relative to the total amount of segments in the lung, and then say after their operation, well, what are they going to be left with? And that percentage predicted is based on, what I always tell the patients is the perfect version of themselves. It's their gender, their height. So it's not my lungs compared to your lungs. It's your lungs compared to the perfect version of you. So that gives us a good idea of how far we can push. Is 40% a hard number? It's soft around the edges. The European societies will go a little bit lower, and so will the surgeons here. I mean, we'll kind of hedge a little bit. And so if we think, upper lobe predominant emphysema, upper lobe tumor, maybe it's going to be fine. Maybe someone has preserved diffusion, but not as good of a spirometry. We know the diffusion capacity predicts their outcome better. So DLCO of 55 as opposed to an FEV1 of 30 something. Say, all right, maybe we can still get them through. So we make that decision. The other big piece, which is probably not one that is well quantified, is just what do they look like walking down the hallway? You got to see that they're functional to begin with, because the biggest component of recovery after lung resection is mobility. We want them out of bed the day of the operation, taking a walk. You sit in bed, you get atelectatic, you get a pneumonia, you pour pulmonary toilet, you're not coughing. So the more they're up walking around, the better they're going to do. So if they come in with comorbid conditions that are maybe unrelated, maybe they've got really bad arthritis, maybe their mobility is fairly limited, we have to start thinking maybe their lung function's fine, but are they going to get through this without a pulmonary complication? Are they going to end up with a DVT or PE because they're just not mobile enough? So those all come into play when we're making decisions about what they're going to tolerate. The fringe cases with severe lung disease, your fibrotics, your severe emphysemas, your pulmonary hypertension patients, those you got to tread pretty lightly because you can definitely hurt patients. And in an era where there are other very good therapies, you don't need to do that.
Great point. So is that 40% cutoff? Is there a cutoff for the fibrotic patients, the pulmonary hypertension patients?
That's the cutoff essentially that we use as the sort of generic number for everybody. But for a fibrotic patient, you might see, if you calculate it out, they're going to land at 40, but you got to think real hard about if that's a real number you're dealing with. Yeah. Those restrictive lung patients, their lungs will not hyperinflate. They're very stiff. So you get a space left over. You get an effusion. You get a fistula. You get an infection. So it's not just that. So you got to be real careful with those patients for sure.
Great point. And question for both of you, in a multifocal or a disease case where you're offering multifocal therapies, are you checking pulmonary function testing, either of you?
As a pulmonologist, absolutely.
Yeah, sure. Poor question for you. That's a good point. Yeah.
I'm checking so much as I chart biopsy the patient and see if they've had PFTs. Certainly, if the patient looks like they have significant pulmonary disease on imaging, emphysema or fibrosis, I would like a baseline set of PFTs.
Sure.
However, the reality is that in the literature, through multiple series on lung ablation, there has been no reported incidence of permanent decline in PFTs. And that plays out in how we see our patients perform after their procedures. It's not to say that we have not had patients that we've at least temporarily, put over the edge into which they were having significant pulmonary symptoms and even pulmonary failure, but the incidence of that is exceedingly rare. And so I can say that in my practice, I've treated a patient who we could present their case later, patient with a lobectomy, severe emphysema, or at least moderate, with 25 rounds of thermal ablation to treat 25 separate tumors without any decline in his lung function or his performance status.
And that's a great point. I guess I'm kind of also getting at the point that, obviously in the surgical literature, this is standard of care to get pulmonary function testing.
Everybody gets them.
Everybody gets them, right? In the IR literature, I don't think it is. Pro-con on maybe it should be, maybe it shouldn't be. I don't think we're there yet. But, as we get more aggressive, maybe we should be. So
I think as we get aggressive, I think it's outcome-based. I mean, it's clear from the surgical literature that this has major implications.
Yeah.
And in the interventional radiology literature, less so.
I think it's important in the sense of prognosticating someone's outcome. If you have a relatively early stage lung cancer and they have end stage emphysema, and their prognosis from their emphysema is 12 months, and their lung cancer prognosis is 5 years, then why treat the lung cancer? So I think it's important from that perspective as well, not just from can they tolerate the procedure, but is that cancer going to be their life-limiting process?
Surgical techniques. What are the minimally invasive options that you give to a patient?
Sure.
Obviously, the properly selected patient.
Yeah. So if you've got someone who is coming in with, staged, diagnosed, lung malignancy that you're going to be planning for definitive resection, the options for types of operations, I would say we'll kind of go through the categories. One is how do you approach it, and then two is what are you taking out? So the first is the approach. So traditionally you would do what's called an open operation. You get a rib spreading thoracotomy and a lobectomy with a mediastinal lymph node dissection. That is a very effective and well-described operation. Most general thoracic surgeons can do it, and it's perfectly fine if that happens, but it's not the preferred one, either for the patient typically or for the surgeon. The more modern ways of doing it now in the minimally invasive setting are you have the VATS approach, or the video-assisted thoracoscopic operation. That is a operation performed at the bedside by the surgeon, typically with anywhere from 1 to 4 or 5 incisions. They're on the order of a centimeter or 2. The operation itself is the same as the open operation. It's still a lobectomy. It's still a lymph node dissection. And then the most recent, and probably now what most patients are asking for, is a robotic operation. The robotic operation is not a bedside operation by the surgeon. They place the trocars, or the ports, use the robotic arms into those ports, and then are remote from the patient, remote by a few feet in the same room typically, and perform the operation on a console. The advantage of each one of these is, or of the minimally invasive over the open approach, is typically that they're less painful. That's number one. There's just no way around that. It hurts less. Number two, blood loss, length of stay tends to be a little bit lower because it's less painful and it's less invasive. Oncologically, they are probably totally equivalent operations across the board. So any one of those, if you get it, you're going to get a good cancer operation, but recovery is going to do better with the minimally invasive approaches. The newest and not yet sort of prime time approach is the single port or single incision robotic operation. That there is a device that is approved for the use for thoracic surgery now that is beginning to get deployed across larger centers, but the experience with lobectomy or anatomic lung resection is still very limited, and so it probably will be the same outcomes with experienced operators as any of the other approaches. But right now, I'd say the majority of patients can and should be getting a minimally invasive operation, whether it's VATS or robotic. Both of those will get the job done.
I'm curious, from a training perspective, current cardiothoracic fellows going through training, do you think it's harder to learn VATS or harder to learn robotic?
Yeah, good question. My opinion on it is it's harder to learn VATS. And so I trained in the transition era of lobectomy for robotically. So I was a VATS surgeon when I started. And I transitioned into robotic now, which is now the bulk of what I do. I personally find VATS to be harder, and that's just me as an individual surgeon. It's tougher because it's a 2-dimensional operation. You're operating on a fulcrum. It's a 3-dimensional space that can be very hard to interpret. The hilum can be challenging if you're 3-dimensional space but 2-dimensional view. And so it is tough. It is tougher to do. There are exceptionally good VATS surgeons out there who can do this like that. It's just their brain works great and they can do it. Their outcomes are going to be equivalent to a robotic one. Robotic operations in general mirror the technique for an open surgery more because it is a three-dimensional or binocular view. You are going to be approaching it the same way you would with wristed instruments and an ability to move the lung around like you would if it was open. So the way you do it will mirror that more. It's real movement. It's not fulcrum movement. It's not operating in a mirror. So robotic has challenges in terms of just being a minimally invasive technique that you need to learn how to do well, but it is more aligned with what an open operation looks like. It just feels the same. VATS feels different. It is not the same operation. The approaches are designed to be different. So in the training era, people are still learning how to do both, but I suspect that the majority of surgeons are probably going to start becoming more robotically oriented and less comfortable with anatomic VATS. For like wedge resections and things like that, VATS is very effective. And most people can do that. It's not as complex. But for anatomic resections, I suspect surgeons will be transitioning over the next like 10 years to where almost everybody is comfortable doing robotic operations. Fewer will be comfortable doing VATS anatomic operations. And open surgery will still be a thing, but believe it or not, can actually be a challenge. We see that with trainees who are uncomfortable with it because they feel like converting from a minimally invasive to an open approach is a failure, and that's just not the case. That's a smart choice. And in fact, they should know that you're making a good choice as opposed to flailing in an operation to try and stay minimally invasive. They're just afraid of it because they haven't done it before. They haven't seen very many of them before.
I was going to ask that, like, is it becoming a lost art? And if it is, and trainers are not being trained in it as much, what's the downside of that? But I think you touched on that.
Yeah, absolutely. People still need to have it, but it's really, the conversion rate for most robotic operations in experienced hands is in the single digits. I mean, our institution with, the number of surgeons who do it, it's probably like 2 or 3%. So it's very, very low. But that percentage is a relevant one because it's usually for a good reason. So you have to be able to do that effectively.
Yeah, I think that's really important for we as interventional radiologists to remind ourselves as well, because we don't accept failure. And often we'll just be like beating on the same door that's not working. And it's important to keep in mind that at times, even bailing and coming back another day is fine. That's probably not an option once you've started thoracic surgery, but it's something for us. The other thing that comes to mind for me is there's a push, or at least the beginnings of a transition for IR to move into the world of robotics. But to me, the use case seems uncertain. Like, why? Because our procedures are already minimally invasive.
Yeah.
It seems that in thoracic surgery, there is a reason. It's that the patients have better recovery and less pain. Are there other factors that really come into play that make this more optimal for the patient?
Yeah, so why is robotics, what's better about it, I guess? I think really what's better for the patient is because it's better for the surgeon, which is it's a more comfortable operation. So it's more straightforward. Again, the instrumentation is very, very good. The newest iteration is extremely good. Again, wristed instruments, tactile feedback now exists, which it did not before. So you have force feedback on how hard you're pushing on tissue. The view is binocular, so you're three-dimensional. You can be a millimeter away from the tissue and be looking right at it. So it just makes it an easier operation to do once you're capable, once you're sort of trained on it. And then your recovery is better. So, I mean, routinely now, a lobectomy, or really any anatomic operation, segment or lobe, patients should be leaving the hospital in like 48 hours or less. In fact, many are leaving the next day. There's even centers that are looking at same-day discharges for these folks. Wedge resections for sure can be done same-day discharges. So we've really tried to push that envelope a little bit in terms of recovery. And so if we're selecting the patients well, we have a very high expectation for success. So we should have low complication profile, good recovery, back to normal life, cancer is behind them. Like that's the goal for these things.
I want to answer your question about robots, or your thought about robots, Scott. I mean, I think in the IR space, the hope is that robots will help democratize a skill set. A complex ablation is still a complex ablation. If you don't have the experience and just haven't done a lot of that intervention, complications, adverse outcomes are a little bit higher, right? And so I think the hope is that robots or that kind of technology will democratize that space for interventional radiology. Now, that being said, if you don't have a return on investment, that's a tall order, and so I think we have a ways to go, but I hear you completely. It is a little bit of an unknown in my mind as well.
Do you bill for the robot? Is that?
Yeah, good question. Currently, there is no separate billing code. It bills the same. There is a code you tag onto it, but it doesn't change the reimbursement from the payer. Pays the same as a VATS procedure. There have been a few studies where people have looked at cost effectiveness, and they're probably pretty close. The way a lot of centers purchase their robot is sort of this like pay to play model. So they're basically giving you a device and you're paying for the reusables. It's kind of like it's like if you buy a printer, right? The printer costs $8, the ink costs $100. So so we're using instruments they're reusable, but they have a shorter lifespan. So all of that, the staplers, we use those, so you get a bunch of devices for a lower cost, but then you're paying per click essentially.
Interesting. So you're not paying for the entire system.
There's a lot of different ways that they will try and get those systems into the hospitals, because for them, obviously, again, every time you use their device, you're gonna, for me, I do a lobectomy, I'm gonna use 8 staple loads. That's whatever cost per staple load that they get. So, over the course of years or a year and several hundred resections, that's already paid for the device.
And as you said, patients are coming asking for robotic resection.
Absolutely.
Right?
Patients absolutely will ask. They will ask about it. They'll ask if you're going to use a robot. Before, they would ask if you're going to do it, laparoscopic or arthroscopic. They always ask for an arthroscopic test. I'm saying that's, but it doesn't matter. The point is they would always ask for something, but now this is what their expectation is.
And how's that looking in interventional pulmonology?
Yeah, I think what I've seen and personally is that technology has kind of upped everyone's skill by a notch. So people are doing things that are performing at a higher level than they were before. Wherever they were at before, they're doing better. So that's basically what we've seen. And the other thing that I didn't appreciate, I'm pushing 50 now. And at the end of doing like 5, 6, 7 cases in a day, my back's aching, my shoulder's aching. The surgeons appreciate this more than medicine docs in general, I think, and they've been aware of ergonomics for a long time. And the ergonomics is just night and day for manual versus robotic bronchoscopy. So that's something I didn't appreciate as much in the beginning, but I appreciate a lot more now.
Definitely, we realize that in IR as well, so with radiation and the lead that we wear on a daily basis and the repeated number of cases, whether you're percutaneous or transarterial, ergonomics is increasingly important. We're not getting any younger, that's for sure. So I want to go back to something kind of basic just for the viewership. Can you help us define and understand the types of resection, lobar, sublobar?
Sure.
When are you going to wedge out multiple peripheral lesions?
Yeah.
And what stages of disease, things like that?
Yeah, so we'll go from greatest to least, I guess. So the most extensive resection that we would offer somebody, or that exists essentially, is a pneumonectomy. So that's removal of the entire lung.
Only one lung, though.
Only one lung. If you take out 2, it's going to be a rough afternoon. So one lung, the entirety of it. That operation is very much reserved for extraordinarily central or complex cases. Even within that space, we are good enough at reconstructing patients so we can find ways to salvage or save one lobe or a part of the lung and reconstruct them. But that does exist. I would say I probably do 1 pneumonectomy a year at most. It's very uncommon. Below that is your lobectomy. On the right side of your chest, you have 3 lobes, upper, middle, lower. On the left side, you have 2, upper, lower. It's removal of 1 entire lobe. That operation is probably still what would be considered the standard of care for the bulk of lung cancers. And so irrespective of where it is, whatever side it might be on, you're taking out that lobe predominantly because it allows for good local control, but also what we call regional, in that all of the draining lymphatic basin, which drains down towards the hilum or the root of the lobe or the lung, all of those lymphatics come with. So that allows us complete staging for N1, and then we do N2 lymph nodes as well, or mediastinal nodes as well. And so that's the sort of next step down. And that's still the most common operation done in the US for non-small cell lung cancer. One step below that is your segment. So that's a sublobar operation. A segment is an anatomically defined portion of the lung that has a discrete bronchus, draining vein, and pulmonary arterial supply. On each side, they are all the same for essentially everybody. So segmentectomy is now becoming the preferred operation for your early stage lung cancer. So this is your less than 2 centimeter, often peripheral, but not always, but often peripheral, less than 2 centimeter adenocarcinoma, squamous or whatnot. And so that's a good operation. It also allows for recovery of those draining lymphatics and a broad parenchymal or surface margin to make sure that you aren't going to have local recurrence. One step below that is in the wedge resection. The wedge resection is just what it sounds like. It's a non-anatomic thing. You see it on the edge of the lung, you just take a big chunk of it, whatever comes is what comes. There are no draining lymphatics that are intentionally dissected out or removed unless you do a mediastinal lymph node dissection, but even then you're not getting the component of the draining lymphatics of that tumor to the lobar bronchus or the segmental bronchus. The wedge resection is become more popular because of publication that came out a few years ago looking at sublobar resections, the CALS-UB trial, which was an international trial, multi-center trial that included wedge and sublobar, or wedge and segment, as sublobar resections. So people are doing it. I don't personally favor it, to be honest. I think it's not borne itself out in the evidence yet to be inferior, but the ability to achieve a true margin negative, low local recurrence rate, and complete staging is I think limited.
With sublobar and above.
With a wedge as a sublobar component. So I think right now the sublobar that I personally favor, I think that a lot of thoracic surgeons favor, is the segment. So if you're going to do less than a lobe, you do an anatomic segment. You're going to get out the draining lymphatics. You're going to have a good margin. You're going to have the lowest risk of local regional recurrence that you can really generate short of taking out the whole lobe.
What are the presentation factors that would lead you to perform a segmentectomy as opposed to a lobectomy?
Yeah, so I think for segment, anytime that I'm seeing now these stage 1As that are really T1A, T1B, so we're talking 2 centimeters or less, I will consider, and mediastinal staging is negative, PET's negative, there's no distant disease, I'll consider them for sublobar operation. The sublobars presumably will provide a better long-term pulmonary function because you have removed less lung. Does that bear itself out in pulmonary function testing postoperatively? It turns out it does, but to a much more limited degree than we thought it was going to be. And so clinically relevant changes in pulmonary function may not matter for the person with normal pulmonary function to start. For that marginal patient where we are pushing them close to that 40, for example, then yeah, maybe you should consider sublobar for them. But so 2 centimeters or less, early stage node negative, that's who I would consider a segment for. Greater than 2, or between 2 and 3 is kind of a gray zone. People kind of pull that card sometimes and still do it, but you got to start being more cautious. Your upstaging rate goes up. Your risk of a close parenchymal margin and then staple line or local recurrence goes up. And I mean, to be fair to the ablative techniques, surgery should provide a essentially almost zero risk of local recurrence. It's an extirpative operation. And so if we're cheating on a margin and the patient has a local recurrence, then I did a bad operation. So I should be able to achieve a definitive local control over an ablative technique that may have residual, we just don't know, right? And so that's the value that we have to assign to it. And if we can't achieve that, then you should do something different. So if your margin's too close, if it's too central a lesion, then you do a lobe. Otherwise, less than 2 centimeters segments are very much appropriate to do.
And I'm assuming that some of those nodules will be living between 2 segments.
Yeah.
So how is that dealt with?
Yeah, so in those cases, I mean, you can usually find kind of, we'll call those complex segments. So it's like a bisegment. Most of them kind of end up as a bisegment. So each lobe, again, has a few areas where you can say, well, it's kind of hedging between the posterior and the lateral segment. Well, you're going to take them both. It's a bisegment. You still preserve the other, 2, 3 segments in that lower lobe. So it's very much doable in that setting. Middle lobe, I don't know anybody who does middle lobe segments. I'm sure some people do, but it's 2 segments. So they're both coming out. So middle lobectomy is almost a segment in and of itself. But the bigger question that everybody asks, which is why that CALS-UB study was done, is the sublobar going to be equivalent to a lobe? Yep. And so the original study, which was done a long time ago, said the lobectomy was better than sublobar. This is when and to be clear about the study, they were accruing patients in like the early 80s. So they weren't even getting CT scans. Mediastinal staging was, barely done. And yes, lobes did better, but it was not probably a relevant study in the modern era. So there were 2 studies that were done to look at this. The CALGB study was one. That was a Western study of sublobar, which included wedge and segment, compared to lobe. The outcomes for that were that survival was equivalent. So that drove surgeons towards sublobar more, including wedge. The other study that was done was a Japanese cooperative oncology group study, and that one looked at segment versus lobe, but did not include wedge. That study similarly showed similar disease-free survival, but actually a better overall survival for the segments. And the reason that is thought to be the case is that if they developed a secondary malignancy, they could still be treated aggressively for it. So those 2, but they're very different studies for a couple reasons. One was the Japanese study included a lot of all these patients essentially had some ground glass component to it. The CALGB study, that one was almost all solid nodules. In addition, the Japanese study had what I would say is nearly inachievable outcomes surgically compared to most Western studies. They did 1,000 anatomic resections. They had 0 mortalities. That is extraordinarily difficult to achieve as a surgical outcome. So CALGB was on the order of about 0.5% to 1% at 30 and 90 days, which is great. That's a very appropriate number. And so those 2 studies pushed for sublobar for these less than 2 centimeters. So I think the outcomes are going to be equivalent if you select the patients correctly. But in both studies, the regional failure rate was numerically higher. CALGB, it was about 13 versus 9, I think. And in the Japanese study, I think it was 9 versus 5. So there was a increase, but the studies weren't designed or powered to look at that regional failure. And so you can't say that it was any worse necessarily, but in patients who did fail, in the CALGB study, most of the failures were distant. Half of them were distant, or whether you had lobe or sublobe. So in those cases, again, you got to take this big chunk of patients out and say, well, it didn't really matter what we did because they failed distant. So based on those 2 studies, surgeons will offer sublobar for less than 2. Wedge, again, my opinion, should not be utilized, but it is occasionally done. I think segment offers the better operation, the better outcome.
I'd like to ask a follow-up question on margins.
I'll allow it.
Yeah.
I've heard
negative.
different R0, everyone.
Yeah, everyone.
I've heard different approaches to what a good margin is for a cancer. I've heard kind of arbitrary absolute numbers, like for ablation, we're talking about at least a 5 millimeter margin, maybe more, maybe a centimeter margin. So if you are ablating a 1 centimeter lesion and you have 0.5 this side, 0.5 the other, then you're ablating a 2 centimeter volume.
2 to 3.
Yeah. And then if you're doing a centimeter on each side to ablate that 1 centimeter lesion, you're looking at a 3 centimeter diameter volume. For surgical resection, I've heard 2 kind of ways to approach it, an absolute number like a centimeter, and then something to the effect of for a 1 centimeter lesion, you want a 1 centimeter margin. For a 2 centimeter lesion, you want a 2 centimeter margin.
So, so one is, margin should be the size of the lesion. That's certainly one that's told. That we usually apply more for metastasectomy where you're not doing anatomic resection. So you just, if it's a colon cancer met or a sarcoma met, just get a margin that's roughly the size of the lesion. They're usually 1 or 2 centimeters. So you can do that as a wedge. For anatomic resections, part of it is you respect the anatomic planes. So, for example, if I have a lesion that is on the surface of the lung, maybe it even has visceral pleural invasion, right? So you've got a lesion with VPI. What's the margin? Well, the margin is the edge of the lung. It's 0. There is no margin. So you can't do anything beyond it. So you have to respect the plane of the lesion. If it's close to a fissure, well, the fissure is an anatomic dividing point. So you divide the fissure. So it's hard to say. So in those cases, the tumor may not respect those anatomic planes, in which case you have to find ways to take more tissue. But if it is within those planes, the margin is the margins of that lobe or that segment. Now, parenchymal margins are different, which is if I have a lesion a little deeper in the lung and I'm stapling through that lung or dividing that lung, you do need to make sure that you are getting adequate amount, especially because we know that STAS, right, spread through air spaces, that's a problem. Lymphovascular invasion, that's a problem. Large vessel invasion, that's a problem, because in those cases, if I staple through draining lymphatics and there is tumor in those draining lymphatics, I can have a 8 millimeter, 5 millimeter negative margin that's never going to be known until a year later when they recur at the staple line. So in those cases, we always try and get basically the broadest margin that the anatomic component will allow. And if you are crossing anatomic pieces, to your point earlier, then you take the next structure with it. So upper lobe lesion that invades the superior segment of the lower lobe, I'm taking out the superior segment with it. That's just going to happen, and that's the way it goes.
Local recurrence after surgery.
Never happens. No. So, I think that's definitely where the combined modality approach becomes appropriate. I think that's where you have to ask yourself, what was the failure point? So if I do a sublobar and I have a local failure, but no distant failure, you have a conversation, which is, did we do an inadequate operation? Was our margin too close? Was this a high-grade tumor where we needed to be doing more? And if so, can we salvage an outcome with a more complete resection? Alternatively, most of the recurrences in like those two studies were local with distant. So in that case, if it's local failure, but they pop up with a lymph node, it's still regional, but maybe I've already lost that game and I got to call somebody else. And then the last is maybe you have a local recurrence because you did a segment or a wedge on a marginal pulmonary function patient. You didn't have any more you thought you could take. Well, now we're going to have to call up somebody else to ablate or to radiate and go for that. So trying to really, again, achieve that good anatomic resection, that's where we really, really, really need to limit those local recurrences because they can be challenging to manage. They can be very, especially on staple lines on the upper lobes where those staple lines fold right into the mediastinum. And now am I going to ask someone to ablate, this tissue that's sitting on top of the arch? I'm going to call you. No, so not answer your phone. So for these local failure cases, definitely becomes a multidisciplinary effort for sure.
Yeah. What about upstaging? Let's say you go in with the idea or thought of a segmental resection, sublobar resection, and you upstage.
Yeah.
What happens then?
So good question. So going back to one of those studies, CalGB study, the upstage rate for that study was like 5 or 6%. So those are patients who they took for the resection, they resect a node, it's positive. So they didn't get randomized. They got tossed out of that study, but that's what the upstage rate was. And that's probably clinically what most people will see for a well-staged patient, clinically staged, including with invasive staging if necessary. We're still going to see that. I tell patients 5% upstage. It depends how you find it and when you find it. So if you do your normal anatomic resection, maybe it's a segment, take out everything, and then you get told 5 days later, one of your lobar nodes was positive. Well, now they're an N1. We didn't see it on a PET. We didn't EBUS in the mediastinum, it was negative. They're upstaged. They're going to go systemic. Yeah. That's fine. Maybe you did a segment instead of a lobe because it was a 1.5 centimeter lesion. That then becomes a question which surgeons will often ask is, should I go back and complete the lobectomy? My opinion on that is typically no, because this is demonstrating that it is systemic or regional disease. Applying a more aggressive local therapy may not be a necessary component of it now. Now, you don't want to delay them getting their chemo or their immuno by saying, let me subject you to another operation to recover from. So that upstaging does change it. Now, if I go in to do a resection and I find bulky multi-station disease, maybe their pet's old, maybe it's 8 weeks out, 10 weeks out, they couldn't get another one, they're coming from out of town, who knows? Then you gotta reassess what your expectation is, because at that point, to one of the discussions earlier, is we know that with neoadjuvant chemoimmuno, you can achieve extraordinarily good outcomes. If I resect now and they don't get to it because they struggle post-op, or maybe because the immuno effect is, tempered by the absence of antigen because the tumor's out, are we impacting their outcome? So you got to think about backing out of that operation
completely. So you won't resect anything
in bulky N2 disease. Yeah. You got to make a game time decision about that. Well, think real hard about it.
Another question I'd like to ask everyone here is the upstage rate. What is that due to? Is it because there was a delay for whatever combination of reasons between when the patient was staged and then they got their operation and it wasn't there at the beginning, but it's there now? Or it was it couldn't have been detected because it was an intralobal, intrasegmental lymph node, and we were never going to biopsy and find that out until surgery anyways. Or it was just missed. Like it was missed on the EBUS, it was missed on the Mediastinal, whatever reason it was missed. Like what, and to that kind of ultimately trying to get to the question of what should be our goal of from detection and staging to definitive surgical resection? Like how long is acceptable? Is it a week, 2 weeks, 3 weeks, 4 weeks? And I know the answer is always depends. Like a slow growing adeno that's been there for 5 years and it grew a little bit, like we can probably take our time with that one, right?
And it's had multiple imaging
right
that are relatively stable.
Yeah, like that.
It's a very different scenario.
Yeah, but I'm talking about for the solid smoking related, that the ones that we think are a little bit more the CalGB than the JCOG.
Yeah. So I mean that's like the tough transition point, right? Because that's the patient who, all right, I see them maybe in the clinic, they've got a lesion. I say let's get a PET. A week later, they get the PET. We see a bunch of stuff. I say, you need your EBUS, you need your tissue. You get that done. We've got our tissue, and now we've got a 2 centimeter lesion. Your biopsy shows it's an adeno. Maybe it's a higher grade tumor, right? Maybe they say this is pretty poorly differentiated. Okay, so should we send off our NGS, wait it out, which depending on which platform you're going to use, could be a week, could be 3 weeks, who knows? So are you going to wait it out because maybe they have an actionable mutation? Maybe this is somebody who I think they might upstage. I want to push them one direction over another. Or to your point, do we say, are we delaying? Now we're 4 weeks out from when they were identified. I think it's a hard sell for patients to wait, but it's also something where outcomes are better if you get the right therapy in the right sequence at the right time. So I think general philosophy about like cancer in general is that it's a systemic disease, period, right? For whatever reason, patients who manifest local-only disease are manifesting local-only disease because their immune system is working. Because we know, and again, to maybe a point Karen made earlier, even with like circulating tumor DNA, patients who have these positive liquid biopsies, they may never manifest distant disease. So is that a marker for risk? Or, where does that fall? So if you have a malignancy and it's 1 centimeter, you can have, nodal disease. You can have one that's 5 centimeters and nothing. So it's already systemic. So does a week or 2 weeks or 3 weeks lose that window? I don't know if it does. I'm not going to wait 6 months, but I think in still, getting all that information first to be able to give them the right therapy. If you lose a week or two here or there, I don't think you're going to impact their outcome demonstrably.
What do you like imaging before ablation?
Ideally, I want at least a contrast-enhanced CT of the chest. You need to see those lymph nodes, at least to make sure there's nothing bulky there. This is particularly important in the setting of metastatic disease as well. It's very different when we're treating metastatic disease to the lungs only versus lungs with lymph nodes. Lymph nodes, it's fully systemic disease, and probably they're not going to benefit that much from metastasectomy. Do you feel the same way?
Yeah, 100%. I think, if you got nodal involvement, then it's a systemic process. And so you have to, recognize the limitations of your therapy, right? Like I love to think that surgery is the best thing you can do for somebody, but it's a local therapy at the end of the day. So I cannot impact that systemic disease. And, when you look at the old adjuvant trials, right? Half of the patients who get resected, who need it, will never get to adjuvant. They wouldn't get to adjuvant cytotoxic chemo or platinum doublet. But the point is, so many fall off. So if I'm going to impact their ability to get the therapy that's actually going to drive their long-term outcome,
synchronous tumors, metachronous tumors.
Yeah, those are tougher to sort through, right? Because especially, that's sometimes the patient you're seeing who is that younger, never smoker, right? So in what we, I think, have typically done is that's where a great multidisciplinary hybrid approach becomes relevant, which is you think about, do they have one dominant tumor that is invasive, 2, 3, 4 centimeters? Are we going to resect this one? Maybe they've got another small one, but it's got a solid component. So resect, but not resect the other. Maybe it's it's contralateral lung. That's an ablation one, right? That's an SBRT one. Maybe they're on the same side. Fine. We resect anatomically the big one. We wedge the others. We accept that local problem, local recurrence risk. So I think in those cases falls 100% into the multidisciplinary approach, where And we've definitely done a variety of these. For me, it's more often in the metastatic setting for other malignancies, but I'll resect a couple, we'll ablate a couple, we'll radiate a couple. You kind of just piecemeal your way through them. And I think that's a totally acceptable approach. But that's where the next-gen sequencing also becomes really relevant, is make sure that you're dealing with two primary tumors or this multifocal kind of field defect, as opposed to intrapulmonary metastases, in which case now we got to think about systemic therapy differently.
Sure.
Right?
Great point.
When you have a case of this field defect or just innumerable or many tumors, how many do you think need to be biopsied before you convince yourself of this?
That's a tough one, right? Because I think typically I would say if you have two lesions that are the same histology, that show the same, they're going to carry the same mutations, then you probably don't need to keep stabbing away at some. Or maybe it doesn't matter anymore because those tumor patterns tend to be more local, in which case you don't need to look for anything else. Just ablate, 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 ablate. And if something recurs distantly, figure out what their genetic profile is at that point, because it might be one of any of those that ended up manifesting that way.
I think it's really important in those multifocal lesions to look at the scans really carefully to see if they look radiographically different, right? Because sometimes there are differences, right? There's a few cases. I remember one particular one where biopsied 3 different lesions because one looked more solid, and then 2 of them were more mixed density. And the solid one was a small cell. The subsolid one was an adeno EGFR negative, and the third one was an adeno EGFR positive. And then also multiple nodule biopsies, oftentimes smoker, but they had a renal cell, smoker had a colon cancer, smoker had a breast cancer, and we biopsy multiple nodules. And more often than I would have guessed, one ends up being a primary lung and the other one ends up being a met. And that I've been surprised at how often that has occurred. I would think it was a super rare event because historically we would just biopsy one and assume the rest is the same because they look radiographically pretty similar sometimes. And so I think if they have a history of another primary outside the lung, it's important to biopsy. If they only have two or three nodules, consider biopsying more than one.
You kind of bring up an interesting clinical context of multiple cancers. It's not been infrequent that I've been treating patients, say, with limited metastatic lung cancer or just primary lung cancer that then develops or is found to have a very small breast cancer, and they always get it operated on. How do you think about that? Patient has colorectal cancer with liver metastases and no other metastases, and now they have a lung adeno. What do you do?
Yeah, good. These are getting harder. I think that's similarly, I'll fall into the get a multidisciplinary effort for sure. I think trying to understand of the malignancies, which one is going to be the life-limiting one, and then go after that one first. For the colorectal, those patients with complete treatment can be long-term survivors in the metastatic setting. For a lung, once you get nowadays, we do have long-term lung cancer survivors, but compared to colorectal, once it's metastatic, we often lose the game more than they do. So aggressively treating the lung cancer is definitely a reasonable thing to approach. But similarly, if we're saying, well, we found these two things, we don't want to limit or delay treatment of maybe a symptomatic disease in the abdomen, ablate, right? What's the lowest morbidity, quickest thing we can do that's definitive and curative intent? Ablate it, radiate it, and then aggressively treat the other malignancy. And I think that's where as a surgeon, sometimes you got to sit on your hands and hand it off, right? Yes, we could do it, but that maybe is not the best for the patient. It may actually provide them a delay in care, and so get them to a quicker modality, a better
Like us
modality.
for everybody on the multidisciplinary team. Right?
Yeah.
We all have to be cognizant of that. No comorbid conditions, no nodal disease, no metastatic disease. What makes the patient unresectable?
Sure. So I think we touched on it a little bit before. I think, resectability falls into that sort of two-tiered thing, or two axes, the technical component of it and the clinical component of it. And so the clinical component of it is, again, is there disease biology and burden one that is going to be positively impacted with a definitive local surgery? That often is a question that the medical oncologist is answering before they even get to you, right? They've decided whether to refer the patient because of the way this patient looks. The technical side becomes that's the question as a surgeon we have to answer more. And the reality for that is technical resectability is surgeon and patient dependent, right? Can you resect central hilar structures? Absolutely. Can you resect the carina? You can. Can you resect the atrium? You can. Can you resect the aorta? You can. Can you resect any of these vasculature? You can. Those are all technically resectable operations. What would make it not technically resectable? Well, if you have somebody who has invasion into a structure that you cannot reconstruct, so the ventricle, for example, is a non-reconstructible structure, or one where simply the morbidity of it and the expectation is so extraordinarily high where, yeah, maybe you could resect the aorta of somebody, but if this is an atherosclerotic disease, you're going to end up with, descending aortic issues and perfusion issues to the spine. You don't need to paralyze someone to try and get this out when there's other modalities. So I think unresectable structures, there really aren't that many, but when you're done, is that patient who walked in the door going to walk out the door? And so, that's where for sure surgeons should be collaborating with surgeons. Don't go in alone on these bigger cases. Ask another surgeon to look at it with you. In the tumor board's a great way to do it. But that's that tier, that sort of 4-quadrant thing, the patients who are clinically resectable, that technical resectability is where a surgeon can either make a really good choice and get a patient through a very difficult situation or push someone over the edge the wrong way when they did have another therapy option, which could be, chemoradiation or otherwise. So I think getting in touch with surgeons who have expertise in those things is very important.
Do you make use of fiducials?
I have recently, since Scott joined us. They're good. For the ground glass is great, especially when you want to do sublobar. For ground glass that is not in a clear anatomic segment, a fiducial is very helpful. In fact, he placed one for me for a patient just a couple weeks ago that I did. So
good job,
very, very useful to help us, identify the right anatomy.
Sure.
This is not my patient, but it's one that I saw in Tumor Board. This is a patient with Lynch syndrome, has had multiple cancers. I'm not listing them all, but basically getting variety of cancers at a clip of one every 4 or 5 years and multiple organs. Had a left upper lobectomy for a lung cancer in the year 2000 and now presents with a new part solid left lower lobe, what appears to be a lung adenocarcinoma and was biopsied to be a lung adenocarcinoma. What are your thoughts on this from a surgical perspective?
Yeah, so when I'm seeing this in a history of a left upper lobe, so we're talking residual lobe recurrence, or not recurrence, de novo, residual lobe, my first thought would be, how can we save this person's lung? And so we would do, your routine testing, pulmonary function, kind of get them through, see what they really have underneath it all. And then we'd start talking about, is there a way that we can try and preserve this lung for this individual? A completion pneumonectomy is a doable operation, but there is a lot of morbidity. Functional status definitely declines, so there's no way around it. And for someone who may end up with another cancer in their right lung, preserving as much as possible would be the goal up front, I think.
Yeah, Covey, what do you think about this nodule? Could you ablate this?
Yeah, I think both reasonable areas to ablate. Look like you have clean pathways to both.
It's one tumor. This is
this is
one
the same tumor. Oh,
this is axial and coronal plane.
I gotcha. Yeah, I think so. I tend to err on the side of cryoablation a little bit more than microwave, especially when I'm a little bit more central, just from a protective aspect to the adjacent bronchovascular structures. But yeah, I don't think unreasonable if, after the multidisciplinary discussion, we deem that as the appropriate approach. This is not a patient that I would just unilaterally take to ablation without discussing with the entire team.
Would you favor cryo over heat?
To be honest, I think you go either way. I personally would probably microwave this just because it is a little more central, but not that central.
Yeah, sure.
So I just think it would be a pretty quick, easy procedure. Could probably be done in about 40 minutes or so.
Yeah. Would you have to bracket this one, or is one placement enough, you think?
I think there's a couple different approaches. I generally make use of one. So if it's cryo, it's going to probably require 2 probes. Okay. Yep. So you're going to have to bracket it. With a microwave, what you could probably do is get to one side of it, burn, and then readjust the needle, burn the other edge. There's a little bit of like game time decision on how much to get. We kind of look at the post ablation field to see how much we think we're getting. To everybody's point, I think the confidence of what we're actually treating is lacking.
For those of us who don't ablate, bracketing means
Two probes.
Okay.
On either side. The physics of the ice formation, the beauty of ice is that you actually achieve what the company says you will achieve in the tissue that you're in. The issue is that you're not going to get more than that. So you have to build a treatment zone that encompasses the entirety of the tumor and the margin that you're aiming to achieve.
Do you think that vessel right at the superior to it, more cephalad to it, is large enough to create a heat sink effect on this one?
It's potentially large enough. It's potentially large enough. This on the left side image.
Yeah.
That looks to be probably about a 3 millimeter vessel. It certainly could sump away some energy. I think probably in my mind that is another reason I may favor microwave, which is just a little more powerful when it comes to these thermal sinks.
And when you say you put in two probes simultaneously, or you treat and then you move and then treat the other one?
For cryo simultaneously. For microwave, you could move a probe around. There's no ice ball you're contending with, right? But I think, I would not fault Scott at all for using microwave. I think that's perfectly acceptable. But to your point about locally understanding the ablation zone with microwave, that's the challenge and what actually got. So, but I agree. Definitely could be a heat sink and yeah.
And you're saying that because intra-procedurally, the ice ball is clearly visible when you spin. When you do a CT, you can see the ice ball, so you know your treatment volume.
Great question.
And not so obvious with microwave. Is that what you're referring to, or is there something else?
The general technique for cryo is to actually do a very short freeze and then thaw that freeze, let the lung have a little bit of alveolar hemorrhage, and then refreeze the alveolar hemorrhage. So then you kind of get a sense of where that ice ball is. Now, the problems with that, though, are number one, the ice ball is a 0-degree isotherm. And the 0-degree isotherm is not tumor kill. So what you're seeing is not tumor kill. Inside that, you need to get down to the -20 isotherm and those kind of things that'll actually give you tumor kill. So understanding where that isotherm is one challenge in effect. Also, you may not get the alveolar hemorrhage to then refreeze to see where the ice ball is. That's the other problem. So I think on the cryo side, still real-time ablation confirmation is lacking from that aspect, even though you get a sense of where the ice ball is. And then again, on the microwave side, that is the challenge.
But at least you know for sure if the ice ball is not covering it, you definitely didn't get it.
Definitely did not get it.
Right?
100% agree. Yeah, you see the edge of the ice ball.
You can rely on the measurements. With our larger probes, you get about a 1.6 centimeter radius at the center of the ablation zone. That's pretty reliable. And so I fall back on that. Sometimes in the lung, because the lung is low density, it's pretty hard to see the ice, even if there's melting ice that kind of allows you a window. So I just rely on that. And I'll tell you another thing. The one of the beauties about ablation is we talked a lot about, through all of the sessions today, about leaving the doors open, right? This is a patient, we have to leave the doors open. This patient 100% is going to get another cancer. Where it's going to be, I don't know. Is it going to be in the lung? Is it going to be in the kidney? Is it going to be in the brain? We don't know. We just know it's going to happen. So I think pacing ourselves in this cancer, the patient got a pneumonectomy as their first cancer in 2000. That was appropriate, most likely. Yeah. But at this point, we have to be really thoughtful about our local treatment options. Could radiation be used here? 100%. And Alan's not here to defend himself, but I think in patients like this, we really must be considering ablation so that we preserve lung parenchyma, don't distort the radiographic windows of detecting tumor recurrence, and just leave the door open.
Yeah, I agree with that 100%. I will still maintain, though, I know I said it before, I just never trust the manufacturer's brochure for the ablation zone. I get where you're coming from, Scott. It is something that has been kind of, whenever I have a failure, it is often just, I didn't get the predictable ablation zone that I was kind of expecting, right? And I know we've all seen that.
So this is all one patient, so I think from the standpoint of how this all is played out over time. So this is I think about this time, let's call him a 70-year-old guy, pretty decent smoking history, a little bit of emphysema. First time he presents, he has 2 lesions that were clearly identified, but he has a lot of other lesions. The left upper lobe nodule was the one that was the primary concern, but you can see one in the anterior portion of the right upper lobe. You can see some other ground glass nodules hiding in there. So now you've got a patient that like legitimately, when you're looking at the scan, yes, he's got one spiculated nodule that looks most aggressive, but every lobe looks a little bit involved. What are you thinking when you're seeing a patient like this?
Yeah, I mean, I think that's exactly right. There's a bunch of lesions. The one that's dominant, obviously, is you're sort of drawn to that. You see a little speculation off the pleura, so you start thinking to yourself about treating that one, but without anything prior, time is the best metric for what's going to happen. Is what did these look like a year ago, 5 years ago, 10 years ago? Maybe they looked the same. So then, I'd start thinking similarly as the last case is probably extremely aggressive extirpative approaches may be a little risky because we're going to be deep treating things down the line. I also happen to notice what looks like a sternal wire there. So that is another, just a plus in the surgical world, that it's a redo type operation. But yeah, I would be thinking a lot about what the downstream is going to be before extirpating lung aggressively.
Yes. Scott, any thoughts from your standpoint?
Yeah, I mean, I'm the medicine doc, so I want all the data first, right? So I want PFTs, I want echo, I want the kind of how much reserve this patient have. Then I think knowing just this, let's say we have no other scans, this is the only scan that we have, I would probably suggest surgically removing the one in the left upper lobe, the one that has that pleural tethering, because that one looks rather aggressive. The other thing we haven't done yet is proven that this is cancer with biopsies. I mean, I think it's obviously that's what we think it is. Is it EGFR mutated? Is it EGFR not mutated? It's, those kinds of things. Is there mediastinal disease or not? If the mediastinum is clean, then I would multifocal disease, right, with a clean mediastinum, and doesn't necessarily warrant systemic therapy, but of course we'll get medical oncology's input. But I think I would favor a sublobar resection of that left upper one, and then non-surgical treatments for the remainder, but based on follow-up imaging to see which one's behaving badly. So it'd be a game of whack-a-mole to me. Treat that left upper lobe one, then see if the other ones are stable on follow-up imaging. I'm not sure I would go to treatment right away, but I would kind of follow radiographically. And if one starts to get more dense or grow, then whack-a-mole that one, whatever approach makes the best lung-sparing approach for that lesion, and then so on and so forth.
With regard to your initial workup, is this somebody that if they come in to see you, do you think this is the patient that should see you to have a biopsy of the left upper lobe nodule and mediastinal staging at the same time, and possibly biopsy of another lung nodule? Is that something you would consider doing in a patient like this?
I would absolutely in this patient, because that left upper lobe one looks different to me than some of the other ones. So I would biopsy probably the two lesions that look the most aggressive to me, plus an EBUS EUS to look for adenopathy that needs to be biopsied, and then get all the molecular analysis, NGS, et cetera, then decide on that treatment plan.
And Scott, you'd be pretty happy with that workup?
I would agree with that 100%.
Okay. So this gentleman ended up having a left upper lobectomy.
Okay. Got it.
And then I believe they may have removed some small nodule in the left lower lobe with a wedge resection, and he developed growing anterior right upper lobe nodules, which was biopsy proven to be a lung adenocarcinoma. What would you do now? So he's had a left upper lobectomy, wedge on the left, and now he has growing tumor.
I would recommend lung-sparing approaches here, ablation, SBRT, depending on the location, and whichever treatment will be both efficacious and lung-sparing.
Yeah, I mean, even just kind of ballparking from the last one to this one, this doesn't look like it changed a lot if I'm looking at the same lesion. It's over a 2-year span. So similarly, how aggressive do you need to be about anything right this minute? I mean, I don't even know if I would have necessarily needled it yet. There doesn't appear to be much solid component. It's not changing a lot. You can probably get a few more years of observation. But once you know what it is, again, you got to have that conversation with the patient. Lung sparing for sure.
Yeah, interestingly enough, in retrospect, when you look back, he has this nodule hanging out, in back of the brachiocephalic vein, so yeah, which looks at least as suspicious,
right?
So, which was not addressed.
I'm kind of surprised. I thought this was going to be Scott's second pneumonectomy of the year.
Left side first and then right side.
How would you treat this?
In a patient like this with multiple lung cancers, based on ablation's ability to preserve lung parenchyma, I want to leave the door open. So to
100%.
me, this is a 100% ablation case, because I know that some of these other nodules could grow with time that we're not going to treat right away and might be best served with even a surgery or radiation. I want to leave the door open for 100%. Treatment of those nodules. So chip shot, that is your most suspicious lesion, ablation. Alan's not here to defend himself, but anyway, this was radiated. And you can see, poor Alan, but the changes after radiation, they are confusing. It's complete, but confusing. Okay, so this is 2014. We're now 3 years on from the initial diagnosis. And then he comes to tumor board.
With that solid lesion.
With that solid lesion in the right lower lobe. And at this point, all of these ground glass, part solid, it doesn't matter really how much what we want to call them. These are all growing tumors. One of those is the original.
And EGFR, anything targetable on the moleculars?
Nothing targetable.
And oncology doesn't want to give systemic therapy, or they do?
They don't. This was back in 2014, so I think that it might have been a different time point in history. In the current time point, do you think that we might be considering something systemic a little more?
I think for this case, I think this well illustrates this sort of field defect where they're just going to they're never going to stop. You can surgerize away and leave them with no lung, or you can just piecemeal it with the most preserving strategy. I think to the point about which strategy to use, that radiation will lead to a lot of architectural distortion, especially when you're starting to have fields that are getting real close over time. So that will make interpretation of future scans very challenging. So I think ablative techniques where you're going to end up with minimal distortion in the long term and an ability to continue to survey closely is probably a good call.
Yeah, so we went ahead and treated innumerable of these over the years, kind of well-paced. There was no rapid progression, just treated growing and more solidifying lesions. You can see we used a combination of microwave and cryo. He tolerated this very well.
Question for you, Scott. Yeah. When are you deciding, like those very central paramediastinal lesions, as an example, when are you dropping the lung, not dropping the lung, like iatrogenic pneumothorax, essentially?
I introduce an iatrogenic pneumothorax at times when I'm unable to move the ablation zone from where I think the recurrent laryngeal nerve or the phrenic nerve is living.
Yeah.
Anything else I don't care about.
Okay.
Possibly if a lesion was right by the trachea, I need to move it.
Sure.
Usually if we use cryo, we don't need to drop the lung. We can just kind of torque the cryoprobe after sticking it a little bit and move the ablation zone away. The reality is that after all these years, it is only this patient that I ever had intraprocedurally him showing signs of a recurrent laryngeal nerve injury. It was kind of funny because he kind of talks like this. He's got a good smoker's voice. And, we were doing the ablation of that right upper lobe nodule behind the brachiocephalic. And all of a sudden he says, I feel like I'm getting a little more hoarse. And I just immediately turned off the cryoprobe and he was fine.
Yeah.
He was totally fine.
Okay.
So we actually ended up treating 25 of these lung adenocarcinomas. So this does not mean he came 25 times. We often treated more than one. Yeah. So over 8 years. So now we're talking about this man is now, 11 years out. And he shows up one day and this is his interval scan after just having these part solid ground glass nodules. I mean, what do you see here, Scotto?
I don't see anything.
I see a problem.
I see, a lot of FDG avidity all over the place, which is quite concerning.
Yeah.
The immediate reaction for me is this a sarcoid-like reaction or true cancer? So I definitely would want to biopsy these to confirm whether or not these are cancer or not.
Yeah, so he got a biopsy. We just did a percutaneous biopsy of the supraclavicular lymph node, and it was lung cancer, and so it was treated with systemic therapy. And this is 2023, and this is 2024. So after all of that systemic therapy, maintenance, Nevo, all the mediastinal lymphadenopathy was totally gone. And he just had this supraclavicular lymph node remaining, which was radiated. And today he is alive and, doing well.
That's a good case. That's a really good case. Yeah.
Great case.
It's a good result.
This is a perfect example of all patient treatment decisions come down to a clinical trial with an N of 1.
Well, I think this is like it just well illustrates on the other, on the one side of the coin as we see these ground glass sort of things. We just, we never get very excited. We treat. And then, but we don't really understand it, right? Nobody really gets what the behavior of these things is going to be. At some point, something's going to happen. The immune system's not going to be able to survey. The tumor's going to change. It's going to go off the rails. Fortunately, then systemic therapies get kicked into play, and we have good ones that'll work. So that's a great result for that individual.
Well, this patient got 11 years with local therapies and then is now still alive with systemic.
Yeah, I mean, in an era where somebody might have resected or done lobectomy, I mean, you would have run out of gas a long time ago. So I think, keeping that door open for sure is the way you got to go in these multifocal tumors.
Yeah, just thinking outside the box.
These multifocal tumors, I mean, at least anecdotally, our conversations in Tumor Board back when Scotto was still with us would be something like this. Is this a field defect? Is this multiple synchronous primaries? Is this metastatic disease? My thought's always been, well, it's not really metastatic disease, because if you observe this patient in 5 years, they're going to be alive.
Right.
Whereas if they had metastatic disease, they will not be alive.
Right.
Without therapy. And they fare very well, but ultimately something does progress. Right. It may be many years down the line, but it does.
Yeah.
If you keep them around long enough, something will.
Yeah.
Great session. Scott.
Yeah.
Scott. Thank
Scott.
you all.
Scott.
Thank you.
Thank you so much for joining us on Backtable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _backtable onc. That's _backtable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe DeGrazio,
Josh Spencer, and Jaden White.
Design and digital marketing led by Brian Schmitz.
social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.